Hello? Hello, can you guys hear me? Hello?
Yes.
Yes.
Yeah.
Okay. Okay, so we are waiting for Dr. Maheen to join, and she'll be joining the session in a while. And yesterday, as I already told you that we are going to be joined by another tutor, Dr. Moaz. So we successfully signed a contract with him. So we'll be having a brief introduction of him as well. So right after Dr. Maheen class, please just share the link. We'll be having session with me as well as Dr. Moaz, right? Is that right? Hello? Yeah, thank you.
Hello, guys. I hope you're doing good. Let us start the session. I've already waited for 5 minutes. Okay, I'm sharing my screen. And then we also have to do a rapid review, which, if you guys were present yesterday, I did like a rapid review, like a rapid fire with the question and answer session. So I'm going to also be doing it today. So stay tuned for that. All right. Okay, I've started sharing my screen. Okay, so the first question for today is that physical examination shows no abnormalities. Serological testing for strongylides stercularis IgG is positive. Which of the following findings would be most suggestive of an active infection? So we have a 34-year-old man. He has an immigration history. He has no chronic medical conditions. He comes with intermittent abdominal discomfort and episodic diarrhea. He also experienced dry cough and a throat infection. So, what finding is suggestive of the active infection? What do you guys think the answer is?
It's variety for larvae. Understood.
D.
All right, it's larvae. You're going to see that. Yeah. So again, it was more like of a microbiology question. It was kind of given it over here. But again, so you get a strongylitis circularis infection, for example, if you kind of like step onto it and then it penetrates to the skin and migrates to the lungs, through the lungs, and it kind of travels through the intestines, and then intestines, the eggs are present over there. And then they hatch into rhabdiform larvae, then they're excreted in the stool. So you can kind of see larvae within the stool as well. Again, what on the CBC, what will be increased?
Eosinophils?
Very good. On eosinophils. Whenever you have a helminth infection, remember that you will see an increase in eosinophils. So you will also have that. All right. Okay. Then we go to the next question. Is it okay? So temperature is okay-ish. Blood pressure is 125/80. Pulse is 80. Abdomen is non-tender and distended. CBC, serum chemistries, and stool studies are normal. Which of the following is the most likely cause of the patient's diarrhea? Okay, so we have a 62-year-old woman. She comes because of diarrhea. She has 4 to 5 watery brown stools every day for the past 6 months, which probably occur during the day, but it also occur in the night as well. There is no associated hematochezia, melena, etc. Medical history is significant for type 2 DM, and she takes a lot of medications. All right, what do you think is happening?
C, disordered motility of the small bowel and colon.
Why do you think that's the answer?
The medical history has diabetes.
All right.
So it's the
diabetic, how it's called, diabetic diarrhea.
gastroparesis.
No, not gastroparesis, but because our diabetes caused the autonomic dysfunction. So it is related to that.
Okay, so C is the answer. All right, again, so diabetic diarrhea, we understand that, long-standing hyperglycemia causes altered intestinal motility, and as a result, we have increased intestinal secretions. Poorly controlled diabetes mellitus is a very important risk factor for that. Again, it's also associated with smoking, obesity, etc. So you have painless watery diarrhea. It's secretory in nature, so it persists at night while fasting. How do you differentiate between secretory diarrhea and osmotic diarrhea? How? Anybody?
Osmotic diarrhea is more like of lactose intolerance kind of.
Yeah, very good. And how else? So,
It has
secretory
foul smelling something.
No, okay. So secretory diarrhea persists while fasting, and if in osmotic diarrhea, it does not persist while fasting. So if you are kind of removing the trigger, for example, if the patient is lactose intolerant, and if you stop giving the patient lactose and the patient is fasting, the diarrhea will automatically resolve. All right, so the diarrhea will not persist while fasting because you have removed the trigger. In secretory may be due to a diabetic reason. It may be due to any infectious reason. Vibria chlorella is also secretory in nature. It causes a voluminous diarrhea as well. So that's a kind of differentiation between secretory diarrhea and osmotic diarrhea. Okay. All right. Okay. Then we go to the next question. This is an easy question. I'm not gonna ask you easy questions because I know you guys are really great at that. All right. Okay. I think this question was a little difficult. All right. So the patient has smoked a pack of cigarettes daily for the last 20 years, but does not use alcohol or illicit drugs. He is married. He has no outside sexual contacts. Okay. Abdomen is soft and tender. Rectal examination shows a tear in which of the following locations? Okay, so we have a 40-year-old man. He comes to pain on defecation. The pain is really severe, and it subsides within minutes of passing the bowel movement. He has chronic constipation. Yeah, he has not taken any laxatives as well. What do you think is the picture? It's very easy.
This is anal fissure.
Yeah. Fissures, posterior
Yeah,
midline distal to the dentate line.
Yeah.
Okay, so it's F.
Yes.
Okay. Yeah. again, they're talking about, there's a tear within the anal mucosa. Probably they're referring to anal fissures. Again, we know that anal fissures are usually located at the posterior midline of the anal verge. Again, it's because of the relatively poor perfusion of the posterior anal canal as well. Again, why do you think the anal fissure occurred?
Because of the constipation and hemorrhoids.
Yeah, very good. Because of the constipation and the hemorrhoids. How do you treat hemorrhoids?
Ligation or like sitz bats,
Mm-hmm.
With
What else?
ointments.
Yeah, very good. So you try to give laxatives, a high fiber diet. If it does not get relieved with it, you do a hemorrhoidectomy. All right, so you remove the hemorrhoids. That's of course a surgical treatment, but first you will try to manage the patient with a more conservative approach. All right. Again, easy question. Okay. All right. So there is a right lower quadrant tenderness with rebound as well as palpable mass. CT scan of the abdominal pelvis demonstrates a periappendiceal fluid collection. Culture of the fluid will reveal which of the following organisms. So what's happening? That there is this patient who comes to the ED because of fever, abdominal pain, and vomiting. He's had these symptoms for the past couple of days, but he did not seek medical attention. On examination, the patient is ill. What's happening? What do you mean by this? Periappendiceal fluid collection.
it's
Perforation of the appendix.
All right. So maybe they're talking about a pelvic abscess or something like that. All right. So what do you think is the organism that's kind of involved?
Bacteroides fragilis.
Okay. We all agree with her?
Yes.
Yes.
Okay. All right. Yeah. So we know that the patient was talking about a perforated appendicitis, and which kind of went through the abscess. How do we know it's an abscess? Because again, it's a fluid collection, and the WBC count is very high. You will also have fever in the patient, so that's usually that they're referring to any abscess formation. Again, it's always polymicrobial. B. fragilis is again a very common cause of abscesses. All right, what else is polymicrobial? I told you guys this earlier. What other infection is polymicrobial in nature?
Could be infections in the diabetic patients, diabetes
Very
mellitus
good.
patient.
Yeah, very good. Diabetic foot. So whenever they say that they're talking about a diabetic foot patient, which means, they're talking about that the organism is usually polymicrobial in nature. There are a lot of other organisms that can infect the a patient with diabetes. And yeah, okay. Then we are going to go to the next question. All right. On physical examination, abdomen is mildly distended and tentative palpation. Bowel contents appear to be draining to the surface of the skin in the right lower abdominal quadrant. All right. The patient most likely suffers which of the following conditions? It's very... So what do you mean by this? Bowel contents appearing to be draining to the surface of the skin. What does this mean?
Fistulas. Venous.
Fistula. What else? Sinus, that there is some sinus formation, right?
Yes.
Yes.
Whenever you see fever, high pulse rate, it means you're talking about any abscess. Where do you see abscesses, fistula, sinus formation? What disease? Is it Crohn's or ulcerative?
Crohn's.
Crohn's? Okay. Now let us read the question. 28-year-old patient, abdominal pain, diarrhea, treated with antibiotics, not improved. Several weeks after symptom onset, the patient develops a skin lesion over the abdomen. All right. So again, maybe they're referring to Crohn's. So again, they're talking about fistulas, abscesses, sinus formation, strictures. They all are, very, kind of related to Crohn's. In ulcerative, you will also see toxic megacolon. In what other condition do you see toxic megacolon? One is ulcerative, the other is?
Trypanosoma cruzi.
Very good. Trypanosoma cruzi. Again, Chagas disease, you see megaesophagus, megacolon, and what else? Hypertrophy of the heart. What is it? Restrictive? Guys, is it restrictive?
Dilated cardiomyopathy.
Related cardiomyopathy.
Very good. Dilated cardiomyopathy. So again, it's very important that you kind of go through. What's this? Very easy.
Granuloma?
So a 27-year-old woman undergoes nephrotomy for right lower quadrant vein, found to have an inflamed terminal ileum. The involved segment of the intestine is removed and the lesion is observed in the microscope. What's this? What's happening?
The granuloma?
Okay. Where do you see them?
Crohn's disease?
Very good.
Yes, no, this is granuloma.
Okay. So what do you think the answer is?
It's E.
E? We all agree?
Hilbert cells.
Okay. Do you all agree E? Is it E or
Yes,
F,
E.
guys? I'm not E. Okay. Yeah. Again, we're talking about granulomas, cessating, non-cessating, two types of non-cessating you usually see in Crohn's disease, sarcoidosis. Cessating you usually see in tuberculosis, leprosy. Again, high yield conditions are what I highlighted. Again, very easy question. I am looking for difficult questions so that you guys can kind of tell me. All right. Sigmoidoscopy demonstrates white yellow plaques on the colonic mucosa. And biopsy shows that the plaques are composed of fibrin and inflammatory cells. Further question regarding the patient's trip to Mexico is most likely to reveal which of the following events. All right. We have 65-year-old man comes to the ED due to abdominal pain, diarrhea. He drove from Texas to Mexico. Blood pressure is okay. He has fever. Leukocyte count is very high. There is mild generalized tenderness. What's happening? What happened?
Clostridium difficile.
Clostridium difficile?
D.
So we all
D.
agree with me? Yeah. So again, C. diff, colitis, again, any because of recent antibiotic use, hospitalization, gastric acid suppression. These are the three high yield causes. So I told you guys what you treated with fidaxomicin or oral vancomycin. All right. And IV metronidazole for any sort of fulminant disease. What do you mean by fulminant disease? Guys, what do you mean by fulminant
Kind
disease?
of a bacterial?
Yeah, and what else? What do you mean by fulminant?
Acute.
More severe.
A disease that is very aggressive in nature. All right. For example, it's rapid, it develops suddenly, rapidly, and, kind of with great severity, often to the point that it's very life-threatening.
Very life-threatening.
All right.
Yeah.
Yeah, it's life-threatening. All right.
Like
That's
a
what
progressive
fulminant.
disease.
Exactly. So in that condition, you use metronidazole. Otherwise, you give fidaxomicin, vanco. You check for stool toxins. What type of toxins are there in C. diff? Toxin A.
A and B.
Very good. So you check for toxin A and B, all right, on stool microscopy, and it can develop into toxic megacolon. So we talked about the toxic megacolon. It also happens in C. diff as well. And so C. diff, toxic megacolon, ulcerative colitis can cause toxic megacolon, Chagas can cause toxic megacolon, all right. It's very high yield for you to remember. What do you mean by toxic megacolon? Anybody can tell me what does toxic megacolon mean? Come on, guys.
Like
It's not my step
colon
one.
become enlarged. The colon become enlarged and it can easily perforate. It's like the bowel can see easily, like it's full, it's dilated bowels.
Yeah, very good. So again, you see colonic distension and you will see a very dilated colon, and the patient will have abdominal distension, fever, abdominal pain, shock-like symptoms. All right. So you will see a very distended sort of colon. That is what you mean by toxic megacolon. Okay. All right. I want you to answer me this. What does this mean? He took home canned foods to consume during the trip. What does home canned foods?
Botulism.
Botulism.
Botulism. What happens in botulism? What type of paralysis does it
Descending
cause?
paralysis.
Placid.
Very,
Placid.
very good. So it causes descending, and there's this other thing that causes ascending paralysis. What's ascending?
Guillain-Barré syndrome.
DBS. Very good.
GBS.
Again, what? Very good. So what in botulism? What else do you have? What are the clinical features of botulism?
Diplopia, dysphagia,
Diplopia,
floppiness.
respiratory failure. Yeah, very good.
Floppy baby.
Floppy baby. Yes. Very good. So you give anti-botulism toxin in this. What do you mean by undercooked pork? What do you get to undercooked pork?
Tinea solium.
Tinea solium.
Solium. All right. Okay. What do you mean by consumed shellfish? What do you get by shellfish?
Hepatitis A.
What do you get by shellfish?
Cholera.
Hepatitis.
Fibra cholera.
Yes, Hep A.
Yeah.
Hep A.
Okay, so what
Hep A.
if you have a patient? He, he went to a restaurant and he had a lot of pasta and a lot of mayonnaise sandwich, and after 45 hours he started having severe vomiting.
Staph aureus.
Staph aureus.
Staph aureus.
Aureus. Staph aureus.
Very good. S. aureus. Guys, hold on a minute. I'm getting a call. Just hold on. Hi guys, I'm sorry I had a call. Okay. So are you guys following me? Hello.
Yes.
Yeah.
Yes.
Okay. I'm
Yes.
sorry. All right. Okay. So again, that means S. aureus. All right. What if you eat reheated rice? Then what?
Bacillus cereus.
Bacillus.
Yes.
Very good. Bacillus cereus. All right. Okay. What are the three important pathogens that cause neonatal sepsis?
E. coli.
Listeria.
Group B.
Listeria. Very good.
Group B.
Galatea.
Galatesia.
Very good.
Strep Galatesia.
Yeah.
Very good. All right. Okay, so then this question. All right. Laboratory studies show normal hemoglobin, iron, and vitamin D levels. A biopsy sample of this patient's small bowel mucosa would most likely show which of the following. All right. Okay, so we have a 38-year-old woman. She comes to the office due to intermittent abdominal pain and bloating since childhood. The patient does not drink milk because she does not like the taste, and as I eat ice cream, cheese, and yogurt, but they upset my stomach sometimes. All right, there is no associated weight loss, bleeding, or joint pain. The patient has not seen a physician for many years. Viral signs of his physical examination are normal. So what's happening?
Lactose
Lactose.
intolerance.
Lactose intolerance.
Tolerance.
Lactose intolerance.
The
All
intestinal
right.
mucosa will be normal in that
Mm.
case.
Again, so they ruled out celiac. Why? Because they said normal hemoglobin, iron, vitamin D. So if it was celiac, then they would have said that these are abnormal. All right. So again, it kind of got ruled out. Lactose intolerance, very easy. You know, lactose. I told you that it has osmotic diarrhea, right? So how can you differentiate between osmotic and secretory? By fasting. All right. Okay, then we come to the next question. Very easy, very easy. All right, okay. Vital signs and physical examination are normal. Serum chemistry panel, complete blood count and thyroid function tests are normal. Which of the following is the best next step for assessing impaired nutrition absorption in the patient? All right, so we have a 38-year-old patient. He comes to the office with abdominal discomfort and loose stools over the past year. He lost a certain amount of weight. The patient eats a balanced diet that includes a variety of fruits and vegetables, meats, whole grain. All right, he has had no international travel, no sick contacts. Medical history is insignificant. Patient drinks alcohol socially. What's happening?
Malabsorption.
So what do you
So,
do?
You do a Sudan 3 stain to see the fat, I think.
Yeah, you're right. So this was a classic case of malabsorption. Again, you have bulky, foul-smelling stools in that. Malabsorption is a syndrome of impaired. All right, guys, just hold a second. I'm getting a call again. All right, I apologize. Actually, I am on call today, and I'm in the hospital, and it's just for you guys I'm doing it today. Otherwise, I would have canceled it. All right. Okay. So then we go to the next question. All right. Physical examination is unremarkable. Initial laboratory evaluation, including serum chemistry, blood counts, stool cultures, and studies for open parasite is negative. Which of the following is most likely to please in this patient? All right. 60-year-old woman. She comes to the office with intermittent flatulence, crampy abdominal pain, and watery diarrhea. Her symptoms started 2 months ago after she recovered from an episode of acute gastroenteritis associated with nausea. All right. The patient's symptoms are worse after drinking too much milk. What's happening?
Lactose intolerance.
Again, lactose intolerance.
Mm.
Tolerance, yeah.
How do we see that?
So pH.
What pH?
Hydrogen,
Hydrogen.
breath test,
pH will
yeah.
be low, other things will be high.
Yes, pH.
Plus 2
Very
pH.
good. Again, there a classic case of lactose intolerance. Again, a very easy question. It can present with flatulence, crampy abdominal pain, and watery diarrhea after a dairy product consumption. What is the treatment of lactose intolerance? What do you do?
Avoid lactose. Avoid
White
anything.
dairy.
Yeah, avoid dairy,
products.
and you give the enzyme. So you give lactase supplements. All right. I mean, the enzyme was not a problem. It's not over there, so that is why it's creating problem, right? So you give supplements of the enzyme lactase, and then they can consume dairy. All right. Once you give supplements, then they can consume dairy, but to a certain extent. All right. Okay. Then, so this is the last question for today. Then we're going to be doing a rapid fire, which I did yesterday. All right. So urine analysis shows hematuria. A day later, the patient passes a urinary stone. Abdominal imaging reveals several additional kidney stones. Which of the following is most likely under cause? Again, very easy. Crohn's, ileocolitis, comes to the clinic with left-sided flank pain that started in the morning. Patient is 8 on a scale of 0 to 10 in intensity. Patient is colicky, and radiates to the left groin. No nausea, vomiting. What's happening? Why are the stones getting formed?
It's because of reduced intestinal calcium oxalate formation. Because the calcium oxalate formation is slow, and the calcium can bind with the fats, and the oxalate gets free. It can't bind with the calcium, so it can reabsorb in the. It can go into the urine, and there will be the renal stone formation.
Okay, so what do you think the answer
The
is?
the reduced intestinal calcium oxalate formation.
All right. Okay, let us
So
see.
impaired bile absorption. Insert calcium absorption.
Okay, let us see. Yeah. So again, we know that calcium oxalate stones are kind of characteristic of Crohn's disease. Again, it's because of impaired fat absorption, and when you kind of have that, then it promotes calcium oxalate stones formation, and because of that, we have stones. All right. Again, very easy. All of them are like very easy. I feel like GI is the easiest of the modules. And I think that is why I'll probably do my fellowship in GI, because it's the easiest. Other I don't understand. So that is it for today. I'm going to be doing a rapid review. All right. So are you guys ready? Ready?
Yes.
All right. Okay. Patient has high BMI hepatomegaly. What is that?
Fatty liver.
Fatty liver
Fatty
disease.
liver.
Yeah.
Fatty liver. Very good.
Fatty liver.
Hepatic steatosis. All right.
Mhm.
If the AST ALT is greater than 2:1 and there is hepatomegaly, pink mammary bodies, what is that?
Alcohol.
Mm.
Alcohol.
Alcoholic liver disease.
Alcohol, hepatitis. Very good. If the
Hepatitis.
patient
Okay.
has pruritus and anti-smooth muscle antibody, what's that?
It's the autoimmune hepatitis.
Very good. Autoimmune. So a patient comes to you, the patient has hallucinations, trouble speaking, Kaiser Fleischer rings in eyes, low ceruloplasmin, what's that?
Wilson.
Wilson
Wilson
disease.
disease.
Wilson.
Very good. I told you guys this, that if a patient comes to you and he presents with symptoms of Parkinson's and he is a young age patient, most likely go and check the ceruloplasmin levels, because they're most likely referring to Wilson's disease. All right. Okay. So patient comes to you with bronzed skin, high glucose, erectile dysfunction, joint pain. What's that?
Hemochromatosis.
Hemochromatosis.
Very good. Hemochromatosis. All right. A newborn comes to you. The newborn has jaundice for less than 2 weeks. High indirect bilirubin. What's that?
Hemolytic
Physiological
disease of
jaundice.
newborn.
Physiological jaundice.
Physiological jaundice.
For less
Physiological.
than two weeks.
Physiological neonatal jaundice. All right.
Mhm.
A patient comes to you, newborn, persistent jaundice, dark urine, pale stool, high direct bilirubin, fibrosis of the bile ducts. What's that?
Yeah.
That's
Biliary
unconjugated
Biliary
bilirubin.
atresia.
Biliary
David
atresia.
Johnson.
Biliary atresia.
Very good. Biliary atresia. Okay. Then a patient comes
Atresia.
to you with shortness of breath, hepatomegaly, PAS positive, protein aggregates in the liver. What's that?
Ripples.
Whipple.
Ripples.
No.
No, but why the liver?
SOB, shortness of breath, hepatomegaly, PAS positive, protein aggregates in the liver. Go again, guys. Alpha-1 antitrypsin deficiency.
Antitrypsin. Okay.
Alpha-1 antitrypsin.
Alpha-1 antitrypsin deficiency. So you have SOB, you have hepatomegaly, and then you have PAS positive protein aggregates in the liver. That's alpha-1 antitrypsin. All right. You guys are doing good. Okay. Jaundice with stress or fasting, elevated indirect bilirubin. What's that?
Gilbert.
Kevin Johnson.
Gibbon Johnson.
Very good. No.
No, Gilbert.
No.
Gilbert.
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 With stress.
Yes, jaundice with stress and
Gilbert.
fasting,
Okay.
and then elevated indirect, that's Gilbert.
Gilbert.
Okay. So if you have baby with jaundice, carnectaris, and then you have elevated indirect bilirubin, what's that?
Hemolytic disease of newborn.
New.
No.
No, it's the
See, you said
that.
that. You said
Water.
direct jaundice.
No.
Can you come
Trigger,
again?
the heart syndrome.
Can you repeat it? Dr. Maheen.
Okay, so it's baby with jaundice, kernicterus, and elevated indirect bilirubin.
That's UTDP deficient. Try whatever deficiency. The
It's
enzyme
regular.
that
It's regular.
convert that unconjugated to conjugated. I've forgotten to know.
Okay. What else? Crigler-Nahar syndrome. All right.
Oh,
Okay.
Biglenny, huh?
Yes. So I
Yeah.
did not say. I said elevated indirect bilirubin.
Mm-hmm.
All right. And then the baby had jaundice, kernicterus, more forming, hinting towards Crigler-Nahar syndrome.
So how do you differentiate? How do you differentiate Crigler-Najjar and hemolytic disease? Both of them are unconjugated.
Yeah, I mean that's a very good question. How? You can't. But that is why I'm asking you in after Gilbert syndrome, because I wanted you guys to have that differentiation. All right. The other thing is that hemolytic diseases, they usually present after a certain while in a neonate. They, they do not present on the birth, or they do not present within 1 week of the birth. They take time to present. All right. That's the other thing. Okay. So if you have elevated direct bilirubin, you have dark pigments in the hepatocytes. What's that?
Dubin Johnson. Dubin Johnson.
Very good. All right. So if you have
Dubin
elevated
Johnson.
direct bilirubin and you have no dark pigments, what's that?
Roto.
Rotor.
Very good. Okay. What is the disease that's linked with oral contraceptive use and a central stellate scar on liver?
Liver cirrhosis.
Hepatic adenoma.
No, focal nodular hyperplasia.
Focal FNH.
OCT use and central stellate scar. High yield for focal nodular hyperplasia. All right. Okay. What if you also use OCT but you have a solitary lesion in the liver? Then what is that?
Liver adenoma.
Very good. It's adenoma. Okay. What is the disease that happens with arsenic or vinyl chloride exposure in CD31 positive massive liver?
Angiosarcoma.
Very good. Hepatic angiosarcoma. Okay. So you have confusion, flapping tremor, high AST, ALT. What's that?
Encephalopathy.
Hepatic
Hepatic encephalopathy. All right. So you have aflatoxin, aspergillus, cirrhosis, weight loss, elevated AFP. What's that?
Carcinoma of the liver carcinoma.
Hepatocellular carcinoma.
Hepatoma.
Very good. That's hepatocellular carcinoma. Okay. Then you also have hematemesis, distended abdomen with fluid, spider angiomas, and palmar erythema. What's that?
Cirrhosis.
Very good. That's cirrhosis. All right. If you have a really sick kid after aspirin use and you have fatty liver, mitochondrial dysfunction, what's that?
Reyes syndrome. Reyes syndrome.
Very good. Okay. So if you have hepatic vein outflow tract obstruction, you have cancer, polycythemia vera, hepatomegaly congestion in liver. What's that?
Budd-Chiari.
Very good. Budd-Chiari syndrome. All right. If you have inflow tract obstruction and no hepatosplenomegaly, what's that? Come on, guys. Inflow tract obstruction, no hepatosplenomegaly. That's what?
Stones.
No, that is portal vein thrombosis.
Portal vein.
Yeah. So
Portal
that is
hypertension.
vein thrombosis. Why? Because there is no hepatosplenomegaly. There's inflow tract obstruction. How does the inflow tract come into the liver? Through the portal vein, right? So if you have inflow tract obstruction, no hepatosplenomegaly is happening, which means there is something wrong within the portal vein. That's portal vein thrombosis. All right.
Yes.
Okay. Okay. So if you have right upper quadrant pain after fatty meal and stone in the cystic duct, what do you mean?
Cholecystitis.
Cholecystitis. Very good. All right. If you have right upper quadrant pain, fever, elevated WBC, positive Murphy sign, what's that?
Now
Appendicitis.
cholecystitis.
All right. So
Cholangitis.
the previous question I asked was biliary colic. All right, that's colic because that's waxing and waning that occurs after a fatty meal. That's biliary colic. But whenever you have any sort of infectious signs, for example, fever, pain, elevated WBC, then that means that they're referring to any sort of infection that's going on, right? So then it's cholecystitis. All right. Okay. So if you have right about pain, fever, jaundice, hypotension, stone in the common bile duct, what's that?
Ascending cholangitis.
Cholangitis, biliary cholangitis.
Cholangitis. Ascending
Very good.
cholangitis.
Ascending
That's cholangitis. Okay.
Mhm.
What if you have a calcified gallbladder and history of multiple episodes of cholecystitis?
Calcified what?
Porcelain gallbladder.
Porcelain.
Porcelain gallbladder.
gallbladder. Yeah.
Very good. That's porcelain gallbladder. Okay. If you have history of primary sclerosing cholangitis or liver fluke clonarchus infection and jaundice and weight loss, what's that?
Cholangiocarcinoma.
Cholangiocarcinoma.
Very good. And that wraps up our rapid review for today. You guys did great, amazing. I'm really proud of you. If you guys have any questions, and you guys can ask me.
Dr. Maheen, is it possible for you, if you have the list of all this, your rapid fire question, is it possible for us to also send this in the group just for us to just go through again?
So that is the thing. I had my notes and I kind of just go through them, and I just kind of form a question on the spot. And I don't have a particular list. I don't write it down. So I go through the notes and I go like, oh, this, what's this? And like, so I don't have it. But this lecture will be recorded and it will be given to you, so you can go through it again.
Okay. Yeah. Okay.
All right. Okay. Any more questions? No. Okay. I think it's Dr. Ahmed's class. Dr. Ahmed, are you here?
Yes, Dr. Maheen, I'm here. So it was a great session of you, and I personally enjoyed that. It just refreshed a lot of my knowledge as well. Thank you so much.
Okay. Thank you so much. Okay, I'm gonna be logging out. I'll see you guys tomorrow. Okay.
Okay, bye-bye.
Thank you.
Bye.
Thank you, Dr. Maheen.
Bye, Dr. Maheen.
Okay, can you guys hear me?
Yes.
Yeah, that's
Okay. Okay, I have an announcement to make. Okay, so let me just share the link. Can you just please drop down text in your group so that your mates should join? We have an announcement. Yesterday I just told you that we're going to be joined with another tutor, your mentor. So today he's here. He's going to introduce himself. Hello. Hello, can you guys hear me? Hello.
Yes, we can hear you.
Yes, we can hear you.
Yes, we can hear.
So as I already told you that.
Yes, we can hear you.
Okay. So we are going to be joined by Dr. Moaz. He's just joining in a while, and like he's an